Hello, everyone. Welcome to another Clinical Problem Solvers VMR. Today, we will have Dr. Ravi and Hans discussing alongside with me. And we have today a great Ambrish Dino presenting. Dr. Ravi, would you like to introduce her?
Ambrish, are you able to unmute and introduce yourself?
Yes, guys. Good morning, CP Solvers community. I am so glad to be here. My name is Ombish Dino, and I am an international medical graduate from Lahore, Pakistan. And this would be my first case presentation with you guys. And I am really excited to be here.
Awesome. It's great. It's so great having you here, especially presenting your first case. And our other discussant is Hans. Hans, you want to introduce yourself as well? Everybody kind of knows you, but we'll have you introduce as a discussant.
Yeah, I've been on VMR for quite a while now. I'm a graduate from Ross University, and just like everybody else, I try to match. So right now I'm just helping out here and there to make some money too.
Awesome. Thanks, Hans, for volunteering to discuss. Always great to have you. And also your cases have been phenomenal. So if anybody hasn't checked out Hans's presentations, his cases, please do so. So, all right, Ambish, shall we start with the first aliquot?
All right, thank you, Ravi. So the first aliquot, we have a 59-year-old female who comes to the ED with central chest pain. So I saw this patient about 4 months ago, and when she had the symptoms, she was actually hosting a family gathering. During this, she suddenly experienced central chest pain, and this pain lasted for about 15 to 20 minutes. One of her family members took a blood pressure reading at home, and her blood pressure at that time was normal. So the pain then persisted, and then eventually, she went into a quiet room, and she had to take aspirin and nitroglycerin, after which the pain got resolved. So the next morning, her chest pain recurred. This time it was also accompanied with jaw pain, and she also had 2 episodes of vomiting. So by this time, obviously, everybody in her house was quite concerned, and they just rushed her to the ED. So that's all I have for the history of presenting illness. I can also move on to the review of systems, and then I'm going to hand over the mic to you guys. So in the ED, she had palpitations. She had diaphoresis, but she had no cough, no sputum. There was no recent history of any respiratory illness. She was afebrile as well, and the remaining review of systems was negative. All right, Dr. Ravi, you can take over. Thank you.
Thank you, Ambish. That was so well presented. Just so many meaningful comments or descriptors about this patient. But I'm going to turn it over to Hans to see your weigh in on what comes across his mind when seeing a patient with chest pain.
When we see chest pain like this, which apparently is acute, we have our 4+2+2 schemata to rule out the most life-threatening situations. These are first the 4 affecting the heart, ischemic events, so acute coronary disease or attack. Then we have an aneurysm, Takotsubo. I hope I get them all together. And then the 2+2 affecting organs in the chest. That would be the lung, a pulmonary embolism. It doesn't look like it, but we don't know. Or a pneumothorax. But she improved on nitroglycerin and aspirin, at least for a short while. And then we have the other 2, which is an obstruction of the esophagus or a perforation. Those are the most life-threatening situations we have to rule out right away. And we usually do so with an EKG when the patient comes into the ED and taking serial troponins just to see the heart. That would be the first thing that would come to my mind.
Absolutely. So chest pain, I just love that comment that we do have to simultaneously think in 2 modes of thought. One is trying to do some data gathering and trying to address his chest pain. At the same time, initiate diagnostic testing, which should be very quick. So getting an EKG would be pretty quick, and not waiting, because ACS is definitely, I see, at the top of your list. And that is something that you don't want to sort of dwell on and spend too much time trying to work up. So two simultaneous train of thoughts that you have. One is getting into action and ordering those tests, and that will help you rule in or rule out an acute ACS as a cause of this. Yasmin, what is coming across your mind? What are you thinking?
Well, across from this, great. Everything that Hans said was amazing, and amazing case presentation. I think that aside from our 4+2+2, we can also determine if this is a potentially life-threatening cause of chest pain or a non-life-threatening cause of chest pain. That's something that I like to think about when I hear about a patient in the ED. Now, in this patient with 4 months of evolution, I will think that this can be cardiac, but maybe on the side of vaginal. And also there was somebody mentioned, Joseph mentioned in the chat about the chest pain relieved by nitroglycerin. Although we can all think, oh, maybe this is something cardiac. I remember reading a paper from past CP solvers VMRs that the chest pain relieved by nitroglycerin cannot help us to determine if it's a cardiac or non-cardiac cause. I could definitely look into, aside from the ECG that you both all mentioned, I would definitely want to ask if this patient also has had any symptoms of gastroesophageal reflux, or also has any other chest wall syndromes, although it's the differential is really low. And definitely think about in my DDX is going up the angina. I'm sorry if I'm saying it wrong. If it's a typical exertional, non-exertional, and that would be basically on my DDX, like higher up.
Wonderful. I absolutely appreciate what both of you are mentioning here. And it's interesting that this nitroglycerin coming into play. What is exactly the significance? A lot of times we think, okay, response to nitroglycerin should mean coronary artery disease and anginal symptoms like you mentioned. But as Yusuf had mentioned in the chat, esophageal spasm can also be alleviated by nitroglycerin. So is it something that will define if should this put at the top of our list likelihood of angina? I mean, we're still gonna think about it. I mean, of course, there's going to be like you, Jasmine, mentioned, life-threatening causes. But then again, this nitroglycerin is kind of, I don't know if it's a distractor or if it's going to actually augment our list of hypotheses. But what's also interesting, I'm going to sort of reflect on this, the palpitations. Is this something that's significant? So going through palpitations, if you have chest pain and palpitations, actually, if you look in the red flag causes of palpitations, chest pain does actually make it very, very, something very considerable that we have to think about. But if you look at causes of palpitations or non-cardiac causes of palpitations or mimics of palpitations, esophageal spasm is one of them. So, hey, maybe that is actually augmenting the thought of an esophageal cause of this. So I think we're going to sort of have a dual process of thinking right now, not just cardiac. Of course, number one priority will be cardiac, but also what are the organs accompanying the heart in the chest. So there's the esophagus, there the lungs, although we're not getting a signature or signal for lung issues like dyspnea at this point. But yeah, the esophagus is something that's very suspicious, and I'm going to keep on the table as a possible contributor. Just rounding out the other causes, I'm going to put a little schema for palpitations in the chat, but reflux can cause palpitations or mimic palpitations, hiatal hernia, stomach rumbling, and intercostal muscle twitching can be misinterpreted as palpitations. So those palpitations can have an association with esophageal spasm, and as Yusuf had mentioned in the chat, the nitroglycerin could have some bearing on that. But I still would go down the route doing cardiac enzymes and also getting an EKG to determine right at that moment if we're dealing with a burgeoning acute coronary syndrome. Back to you, Ambish.
Thank you guys. I'm loving the discussion so far. You guys are so smart, and with just that much of information, it's like you guys almost know what's going on. And I'm loving the thought behind the esophageal spasm, because that is also something that kept lingering on, into my head as well. So somebody in the chat, Yusuf, you were asking if somebody prescribed it, and I wanted to clarify that. So this, I'm in Pakistan right now, and over here, the way that the drugs are prescribed are quite different from how it's done in the US. So one of the family members was, in fact, a physician, and he prescribed it to her. Right. So that's how she received nitroglycerin. Aspirin she already had access to, so that wasn't a problem. So that's what happened. And then the next morning, now she was with us in the ED, and then we were, doing the rest of her treatment. So I'm going to dive into the second aliquot. Her past medical history, she's been a known case of hypertension as well as diabetes for the past 15 years. And other than that, she's been having generalized anxiety as well as peripheral neuropathy. Her medications included amlodipine, glipizide, and other than that, she was also taking metformin for the diabetes. She does not happen to have any known allergies. And then her family history was non-contributory. She does not elicit any drugs. She does not drink. She's a non-smoker. And that's about it.
Some interesting features in this aliquot. What do you think about this, Yasmin? How does this change your, I guess, the priority of your hypotheses that you generated earlier?
Actually, I will stay on the cardiac issue line. My differential diagnosis on the first places would be definitely cardiac, and like I would put this patient as soon as possible on a 12 lead EKG. Although she has generalized anxiety, we cannot let this be a confounder, for a lack of a better word, for this chest pain. I can also see that she has diabetes mellitus of lung evolution and hypertension of lung evolution as well. I'm sure Amish will share with us the vitals and see if that hypertension has been on control for this past 15 years, because that also puts us on a risk factor for cardiovascular diseases. Now, I would also think about, when I think about angina, I remember that there was a type of like possible cardiac and non-cardiac chest pain. And when, as you mentioned, with palpitation and diaphoresis, I'm definitely on the cardiac causes, or or at the very least, the possible cardiac causes. So I would definitely look into that too. What do you think, Hans and Dr. Ravi?
Hans, you want to take a stab at this?
Yeah, now I just agree with Yasmin. We have high blood pressure, we have diabetes, generalized anxiety, an anxiety attack. These are risk factors for acute coronary disease. So we have to, I would proceed just like Jasmine, she put it right to the point. We have to pursue a cardiac problem until it's really proven otherwise.
Absolutely. I just love that thought. The risk factors definitely do highlight the risk features for this patient for having coronary artery disease. I also saw AMK also put in the chat something interesting, like there could be other contributors or other causes for chest pain, such as coronary vasospasm, spontaneous clot formation, emboli, vasculitis, and so on. So kind of early to sort of delve deep into those possible causes, and we don't have any other associated features to think like inflammation. But I think the next aliquot will help us if there's a fever. The physical exam might help us if there's any other findings, joint findings, skin findings, that actually might make this more of a systemic process rather than just focusing on just maybe the heart or the GI tract. So back to you, Ambish.
All right, thank you. So I'm just going to dive into her physical examination findings first. So her heart rate in the ED was 105, so she was tachycardiac. She also had hypotension. Her blood pressure was 90/60. Her respiratory rate was 18, and very important, she was afebrile. So she was saturating at 94% on room air, and her BMI was 32. So the pertinent findings, were only seen in the cardiovascular system. So those are the ones that I'm going to mention here. So her chest auscultation revealed S1 plus S2. She did not have any murmurs. She did have mild bibasilar crackles, no wheezing, but there was also trace lower extremity edema. As per the JVD, her BMI is quite high. It was hard to appreciate that. The remaining examination was unremarkable. And if you guys want, I can move on to the labs.
I think we can stop there. This is very interesting. Yeah. Yasmin, anything come to mind that's we could split up in the vital signs and then the cardiovascular exam.
With this patient, even though her blood pressure is low, okay, so just a thought here. Whenever I see a patient with hypertension for 15 years and I see 90, 60, I'm thinking, even though this is not hypertensive, I would be vigilant of this being lower blood pressure than normal, just due to my anecdotal experience. That's not like something true for everyone. Now, she's tachycardic, and with these murmurs, and with this mild bibasilar crackles, I would like to see if this heart is not having issues right now and it's causing pulmonary edema, meaning a heart failure, or we're having an acute coronary syndrome. Now I'm thinking also of this, like as Eduardo was mentioning, cardiogenic shock just secondary to AMI. Although it's taking me, like, the only thing that puzzles me is that she had this 4 months ago. I just want to clarify this. If she had this 4 months ago and has been progressively appearing, or this just happened before and now it's presenting again. Amish?
Yeah, so basically, I saw this patient 4 months ago, and we're still in the past. It happened 4 months ago, say 1st May it happened, and then on 2nd May she was in the ED. So we're still there.
Okay, so this might be very well definitely an ischemic event. Although I would definitely wait for the EKG, because these are very on a specific signs for me. There is no JVD. The JVD is hard to appreciate, so I cannot really say that there's heart failure. And yeah, definitely thinking what's happening if this is problem with the heart that cannot pump all this liquid and it's getting into the lungs, or is it a kidney problem? So that would be the two things I would like to look at. What do you think?
Hans, you want to chime in?
Yes, what I was thinking is she has crackles in her lungs and she has trace lower extremity edema. Usually these things require a little bit of, my opinion, a little bit of time to build up. So if it is acute or hyperacute as described in the HPI, we wouldn't expect it to see. So maybe she already had a heart problem that kind of manifested on that particular day, maybe with an ischemic event. I am not sure. So at this stage, going forward with the labs, it's just a guess that I would like to mention that we have normal labs, maybe not, but in all likelihood normal labs. So we might need maybe a chest X-ray, an EKG, and maybe even an echo to see how well her heart is beating. And maybe we can determine how well her heart is being perfused, something like, yeah.
So yeah, very, very interesting. I think there are sort of 2 or 3 hypotheses that we're kind of considering at this point, but I think top of the mind is a thought maybe AMI plus with a major hit to the ejection fraction. So maybe there's signs here in the exam that suggest pulmonary edema and also peripheral edema. But you also have to be cognizant about other conditions. I think in the chat they're also talking about other conditions that could cause such a presentation. So blood pressure being low, although I'm not getting a feeling if the extremities were cool, are we dealing with cardiogenic shock at this point? So mentation could be could take a hit. Also, patient's extremities will be cool, and also we look for signs of end organ damage. So lactate would be high in that case. So the labs would also help us to sort of consider that as a possible cause. But at this point, I think the blood pressure being low, there is a sympathetic response. The heart rate is high, trying to maintain that blood pressure. But ejection fraction will be very, very important. You have an AMI with a new decompensated cardiomyopathy. That is a very grim prognosis. So there is a classification that we do use, something called Killip classification, and the prognosis can be very poor. So at this point, if you do have a major AMI causing decompensation of the ejection fraction, this is quite a serious condition. You have to sort of have two modes of, or sort of maintain a dual process of thinking, treating the AMI and then also treating this patient for the deterioration in their ejection fraction as well. Although putting the patient on guideline-directed medical therapy, or even if there is a stenosis of a vessel or coronary artery, could actually open up the floodgates and reestablish what happens to the myocardium. With diminished blood flow, you could have hibernating myocardium, stunned myocardium, and that also could be contributing to these palpitations that we mentioned in the first aliquot. So at this point, I think that is quite something that we're considering pretty high up in our list of differential diagnosis. The other thing, the pericardium, if we look at the layers of the heart, you myocardium, endocardium, and then pericardium as well. So could this be a pericardial involvement? We don't have a suggestion of pericarditis here, with maybe the pain getting better sitting up forwards. Although the time frame, 4 months, that could happen. And the pericarditis could be a prodrome to a pericardial effusion and then eventual cardiac tamponade. Are we seeing maybe the development of pericardial tamponade? We do have a low blood pressure. We always look for this, the rubbing, pericardial friction rub, but that is intermittent. So if it's there, it can be suggestive. I wouldn't say it's pathognomonic, but it could be suggestive. We don't have that exam finding though. Peripheral edema could actually happen with sort of a more chronic onset of pericarditis, or not cardiac tamponade, but pericardial effusion. So peripheral edema, hepatomegaly, all the right-sided features could be manifested. JVD can be difficult to find, and we always suggest this in medical school. We always mention this Beck's triad, but I've seen a good number of patients that have maybe one out of the criteria for Beck's triad. So here we have hypotension, muffled heart sounds may not always accompany the patient, and you won't always have JVP. So I would also consider this and get an echo in addition to the EKG. The EKG, I think, will be the first order of business and will really help us to see if there's any distinguishing features of current of injury in this patient. If the EKG is normal, cardiac enzymes will be helpful, and also maybe a quick bedside point-of-care ultrasound. Any other thoughts, Yasmin, Hans?
So far, I'm right there with you. I would definitely want to see the troponin, EKG, and also like see if there is any other anomaly on the labs.
All right, and yeah, other things to see with pericarditis would be, or cardiac tamponade, sorry, pulsus paradoxicus. So having a pulsus paradoxicus can actually increase the likelihood ratio for pericardial effusion. But back to you, Ambish.
Thank you, guys. Very interesting discussion. I'm loving it. I'm reliving the whole case through you guys. So all the investigations that you guys want have been done, and I'm going to reveal the results. But before that, never mind. I'm just going to dive into it. So the WBC counts were within normal limits. She turned out to be anemic with her hemoglobin at 9.4. Her hematocrit was 32, and her MCV was a bit low. It was 73. So at this point, we were like, why does she have, what's going on, and if that could have, in any way or shape contributed. Her platelet counts were within normal limits as well. As per her sodium, it was 142. Her potassium was 4.4. chloride 104, bicarb 27. Her creatinine was 1.18, and it was slightly higher than her baseline. Her baseline usually would be around 0.9 to 1. And then her BUN was 20. And then her troponin I was quite high. It was 10. So then we ended up doing her EKG. And I do have a picture that I'm going to share. I came across, I was able to get the EKG picture for you guys to see. So it was quite non-specific. I'm just going to share my screen. Okay. Just a moment, guys. All right. Can you all see it?
Yes.
All right. So as you can see, there's normal sinus rhythm. There were no ST elevations or depression. It was quite non-specific. It did show some probably poor R wave progression, occasional PACs, premature atrial contractions, and this was it for the EKG.
So very interesting. What this patient has now developed bradycardia, and you're right, there are some PACs, but we're not seeing any PR depression, diffuse ST elevations, no ST depressions, no tombstone pans, and nothing, no sort of current of injury in contiguous leads. There's really no pan that I see. Anything, Yasmin, you see your hands?
No, I'm totally there with you. I don't see any difference. The only thing is that for a person, she's supposed to have 100 and something, and it's not showing that right now. So I'm not like this looks so far normal.
Yeah, it is sinus, so there's no other usurping of the primary rhythm. So there's no other like atrial rhythm or ventricular rhythm. Sometimes with an MI, you could have a hit to the bundles, and then you may have another pacemaker within the heart usurp control. But yeah, I'm not really seeing anything. So does that move us away from ACS? But I mean, this troponin, I think now we sort of have to shift our attention to the troponin. Let's it's 1:32. I think we have time. Let's do some breakout rooms. I think this is a great case, actually, Ambish. This is something we see day in, day out, and it's very important to sort of have an approach to this, especially when you're night flow. A lot of in internship, you have night float, and nurses will call you with the patient with chest pain, and being able to work through a case like this is absolutely crucial. So I think we can all brainstorm in some breakout rooms. So I'm going to assign some breakout rooms, and we'll go ahead and discuss in each of them. I'm just going to hang out here. Hello, Robbie. How are you? Anne-Marie, what do you, since we're just in this room, what are you thinking?
I feel like it's too early to say. I mean, I think it's like you've got to kind of see it into completion, get serial ECGs, because the question is it the ECG normal because it's a transient phenomenon happening in the coronary arteries, or like an arrhythmia, or it just like needs more time, or is it normal because it's happening in an adjacent organ that's, radiating to the chest? So TBD.
Yeah.
What does everyone else think?
Oh, I think we joined the room, but I'm kind of excited to see what people are thinking, because it's a toss-up. It's like we pretty much discussed everything that is relevant. But you know what? Something about that EKG with the slow rhythm.
Yeah.
What comes to mind is right-sided MIs, and do we need to get right-sided leads?
Yeah, and there was a little I thought like a very small amount of ST depression, perhaps into it was like a little hard seeing it on the screen. So again, I think it will become more clear with time. And then I was also curious with the initial vital signs, had she gotten like nitroglycerin before they were taken or not? So
Oh yeah, the blood pressure being lower. Yeah.
yeah. So I was like, oh, like, maybe that could point to possible right-sided disease, but I feel like this could go so many different ways. And it's like someone that you're going to watch really closely and like see what their troponin is and see what their serial ECG shows, and then consider like, doing a CTA if that is not revealing. So
Absolutely. Yeah. I think what you mentioned is important to do serial EKGs. I did have a case, and this patient, he was mentioning the pain was going like up and down in the center of his chest. So I was like, it has to be an aortic aneurysm, or sorry, aortic dissection, and that was negative or negated by a normal CTA. And I think I did 6 EKGs while the troponin was cooking, and the first troponin was negative. The 6th EKG was positive, had ST elevation. So you're right.
wow.
It could be disclosed after. So he was in the process of causing that current of injury.
Yeah. And even just, like if it is something like spasm or something like that, that can be like a transient phenomenon. It's
Absolutely.
like the key would be getting it during an event, which can always be a little difficult. So we'll be curious to see how things progress.
Yeah, that's a great idea. Yeah, the troponins do signal that there's some sort of injury or pressure related effects on the heart. But yeah, it'll be interesting to see what pans out with this case. I think I'll bring everybody back. I think they had a couple of minutes. How are you, David?
Fine, I pressed the button without being without wanting, so I skipped there.
Okay, great. Welcome back. We didn't stop the recording, but yeah, so while we get back on track, anybody want to share what they discussed in the room? Anything came up or with the EKG now and the troponin and all the details?
Well, we were talking about in our breaking room. Everybody shared amazing thoughts about like this troponin. Could this have been something for this level could have been maintained? Can be high, can stay high for quite a time. So we don't really know if this patient had ACS before, something a cardiovascular event before, and now we are like seeing the aftermath, and we cannot really say if this is something happening right now or it is just the aftermath what we're seeing.
Yeah, that's a great thought. I think Adam, how are you, Adam? You were in one of the rooms. Any thoughts to share about what you may have discussed in the room?
we're in the same room actually. I
Oh,
think, right? So, but yeah, I love the point came up. Yeah, like well, one of the points was also just the question is like is the person, because you always ask yourself, is this person in active ACS right now? And I just came off service, had a couple middle of the night chest pain calls to bedside, and had to think about this, and and I think like it doesn't look like active ACS now, but I think the point that they still could have, because the troponins can remain high for days, and so we don't know how high it was before. I think is a very, very good one. So, but is a person going to the cath lab? And I think our group was saying, I don't think that we have to rush into the cath lab right now.
Yeah, that's a great thought. I think in the meantime, I'll get an echo at least, because you're right. This sounds like there's been some myocardial injury. Now, this patient has crackles. This patient has lower extremity edema. We don't have a BNP. If the BNP is elevated, pro-BNP is elevated, maybe that will also augment the likelihood of this being MI with subsequent myocardial injury and development of heart failure with reduced ejection fraction. Or now we have new nomenclature with I think it's what I don't remember, moderately intermediate ejection fraction. Somebody may have to correct me, but there's a newer intermediate, I guess EF between 40 to 50%. That is a new nomenclature as well. So yeah, that takes time to develop. So it's not an immediate impact, I would say. So you don't just have an MI and then develop lower extremity edema and crackles. That takes time to develop. So I really like that thought as well. Anybody else want to share? I see Mario there. Long time I haven't spoke with Mario, but any thoughts before we move on? How are you, Mario? Long time.
Yeah, I was in the same breakout room as Adam, and yeah, so I agree. Yeah, it was a teaching point for me. I was thinking more of this case of an acute decompensated heart failure. But the curious thing for me is that although the history is very compelling, the physical exam is quite negative. So that's something of curiosity for me. So yeah.
Interesting. Yeah, what you just mentioned also triggered in my mind a myopericarditis, where you can have pericarditis with myocardial involvement. So troponins will be elevated, and also you will have a reduced ejection fraction. So again, that highlights the importance of probably getting an echo or point of care ultrasound. And actually, Anne-Marie actually mentioned a couple of things. I stayed in the main room. She actually had a few great thoughts. You want to share what we were talking about, Anne-Marie?
I can definitely share. I feel like I did not realize the troponin was elevated beforehand. I'd be curious what the reference range of that is, because I don't know if it differs where it is, and so that's going to be really important, because depending on the reference range, that helps. And then the delta troponin is also going to really be important, because that will help differentiate whether it's rising really high or if it's staying stable or going down. That would be more consistent with perhaps like an old injury or a secondary process in kind of regards in with the reference range. So I'll be very interested in like the trend of the troponin. But we were just talking about like the ECG was rather non-specific. Maybe there was a little bit of ST changes in 2, and there was also some bradycardia there. So saying like, is this something like a right-sided MI that we're just not capturing it, with the right leads, or was this like some sort of transient event that occurred, and so we just didn't capture the ECG in the time. So just the importance of trending, as well as the troponins, trending serial ECGs as well, to try to get a better idea of what could be going on. And then I think, POCUS is going to be a really important tool as well. And then like from there, and seeing the delta troponin and the trend is going to help inform next steps after.
Awesome. Yeah, that also triggered. There is a CPS schema for troponin. I guess it's called a troponin pyramid. So troponin does not equate with ACS all the time. It could be due to many other things like pulmonary embolism, myopericarditis, and other causes. Even trauma to the chest wall, such as an MVA, can release some troponin. Even tachycardia can cause release of troponins. So let's see with the next aliquot. We'll move back to Ambish.
Thank you, Dr. Ravi. So we did do her x-ray and it revealed some interstitial edema in the bases of the lungs. And it was an AP view, so we could not really appreciate any cardiomegaly. And as per the echo that I feel like everybody is now waiting to know what was going on really. So her echo revealed left ventricular global hypokinesia. Her ejection fraction was reduced, it was 31%, and her IVC measured around 2.2 centimeters with less than 50% respirophasic variation. And that is it for my third aliquot. If you want, I can move on to the fourth one, or I could just stop here.
Does the fourth aliquot reveal the diagnosis?
No.
Okay.
After the fourth one is when I reveal the diagnosis.
I guess we can go to the next one and then we'll stop for final
All right.
comments. Yeah.
Yeah. All right, let's do that. So in the ED, we started her on aspirin 325. We started her on a heparin drip, and then Lasix 40 mg IV, as well as metoprolol tartrate 25 mg. And then we consulted cardiology, and then she was transferred to the CCU and kept there overnight. There weren't any acute events except for the fact that her hypotension kept deteriorating. And all we did was we just stopped her beta blockers, and it did seem to help with the hypotension. And I'm going to stop here and we'll move on to the final investigation and the diagnosis.
Extremely intriguing, Ambish. Your presentation is absolutely stunning. It's you're presenting in such a professional manner. I think once you become an intern, you'll be a rock star presenting cases. So I really applaud you for the way you're allowing this case to unfold. But I'm going to turn it over to Hans to now ponder over this new information. Does it change the thinking or approach to this case for you?
No, actually it doesn't. We have hypokinesia of the left ventricle, and that could explain to at least a certain extent the crackles in the lungs. So we do have kind of a backlash into the pulmonary system and maybe even the lower extremity. So what has caused the hypokinesia? And here I was thinking maybe she really had either a vasospasm of her coronary arteries, which is reversible completely, or she indeed has some ischemic event, which is related to her past medical history, which is diabetes and hypertension, which could be an MI. Or I was even thinking about anxiety, maybe it was Takotsubo. And then we have a form of heart attack, and I forgot the name of it, Minoka, which might fit in here just as well. So it's still everything centered around the heart without a 100% diagnosis at this point, at least for me.
Absolutely wonderful. Yeah, Minoka definitely does come in. Is this, you're kind of thinking about two different things: obstructive myocardial injury, non-obstructive myocardial injury, and then heart failure with reduced ejection fraction also that's within this landscape of this problem here. But Yasmin, any other thoughts before we kind of maybe consider a final diagnosis?
Yeah, like just amplifying what Hans mentioned, this ejection fraction will put me on the setting of a heart failure with reduced ejection fraction because it's less than 35. And then I will think maybe on my differential diagnosis, keeping high the possibility of coronary artery vasospasm or an ACS. Yeah, definitely see what else is in this, was in the next aliquot.
Yeah, just I think we are dealing with probably this patient had stable MI or stable angina, and then at some point became acute unstable angina, and then subsequently went on to develop myocardial infarction. As far as the the management, it seems from that EKG, the patient became quite bradycardic. And again, if this was, say, a right-sided MI, we definitely would not give nitroglycerin. That would be detrimental to this patient. The other thing I just want to comment on was the beta blocker. And if this patient has subsequently developed an acute case of heart failure with reduced ejection fraction, or decompensated heart failure, I should say better, we always learn that metoprolol should not be initiated because you could actually move this patient into cardiogenic shock. So I think somebody that's naive to beta blockers, this is the first episode of decompensated heart failure. Metoprolol is one of the meds that reduces mortality, morbidity, but we would have to make sure this patient is compensated before starting on metoprolol. So by starting him on metoprolol, this patient became hypertensive and they had to be taken off of the beta blocker. I think Lasix is reasonable to at least help with the dyspnea that the patient has now developed. And I think cardiac cath is warranted as far as the workup of this cardiomyopathy. So I'll turn it back to Ambish.
Guys, exactly what happened, the exact series of events, you guys are narrating it for me. So yes, she was taken to the cath lab the next morning, and like you guys already said, there was no obstructive cardiac CAD. There was no obstruction whatsoever, but she did have severe enteroapical hypokinesia with apical ballooning. And Hans has been saying it, all of you guys kind of already knew. And I was like, oh no, what's the point of even moving on? They already know what went on. So she was diagnosed with Minoka. And I'm quite amazed that Hans mentioned the term, because for me, it was a relatively new term. And when I was actually about to present this case, I was actually curious as to how many people would be familiar with the term Minoka, because this was my first time ever coming across the terminology. And I also know that it is a relatively common term in Pakistan. So I was quite amazed that Hans, said it. And then this is a type of, it was a case of Takotsubo cardiomyopathy. The first, like when Hans started listing the differentials, he said it and I was like, oops. Anyway, so it was Minoka, which basically stands for myocardial infarction with non-obstructive coronary artery disease. And this was possibly a case of Takotsubo cardiomyopathy. And for those of you who do not know, Takotsubo is actually a Japanese term that means an octopus trap. And I found this so interesting. I actually pulled up a picture from Google that I wanted to share with you guys. I'll just show it to you. But you guys were right on point the whole time. So let me share my screen and I will show you guys what Takotsubo looks like. And basically, the left side of the heart looks like the octopus trap, which is where the name comes from. All right, can you guys see this? How cool is this? Yes. So basically, I really want to know what Dr. Ravi has to say. And Hans, I think you must, I'm going to applaud for you.
Ambish, I first want to say this is such a great case to bring to VMR. Sometimes we love these esoteric cases, but we don't usually deal with this day in, day out in our practice. And just like I talked we mentioned, Adam just did some night shifts, and probably had seen, we get episodes of patients with chest pain, and we actually have to go through this exact same workup and consider ACS as a cause, but we still have to do our due diligence and work up ACS. But within that workup, Minoka does come up, and STEMI may come up. So definitely we do have to do our workup, though, because the mortality associated with STEMI is quite considerable if not treated within an appropriate amount of time. So I really appreciate this. And what's interesting, ever since this was discovered, we're diagnosing it more and more and more. And I think as far as the prognosis with beta blockers, because the pathophysiology is just unobstructed sympathetic stimulation of the myocardium due to anxiety and stress and so on. So beta blocker will help with at least preventing further aggravation of the myocardium and allow some time to heal. So there is reversibility. I don't know the exact amount, I don't remember if with this low EF, do they have the same dynamic of life-threatening arrhythmias? So I have seen patients go home with the life vest and then follow up within possibly 3 months to see if there's any reversibility of their low ejection fraction. But I think it's something to consider or maybe look up and then learn about. Any reflections, Yasmin or Hans?
No, just thank you very much for this wonderful case. Because I knew about Minoka, but I've never seen one except, yeah, maybe in a report.
Definitely amazing. And answering Nappreet's how do we treat patients with Minoka? I'm not very sure. I just know that with Takotsubo, with no obstruction, the guidelines mention that inotropic support with milrinone or levosimendan, but I'm not very sure.
I just put in the chat a graphic with some teaching points as far as Takotsubo, or what we call broken heart syndrome. But we'll turn it over Francisco for teaching points.
Sure. What a great case, great presentation. A lot of people involved in the discussion, which was amazing, very dynamic. So yeah, I'm pleased to start the teaching point. So we had a 59-year-old female that presented to the ED with 4 months of chest pain. And when you think of chest pain, we need to use the mnemonic 4+2+2 to exclude the life-threatening causes. And those are 4 cardiac, ACS, aortic dissection, tamponade, Takotsubo, 2 pulmonary embolism, pneumothorax, and 2 esophageal rupture and impaction. Then our patient actually had her symptoms kind of resolve with nitroglycerin, but we got to the conclusion that it doesn't really increase the probability of having a cardiac cause. Actually, the positive likelihood ratio is 1.1, and we have other causes that respond to nitroglycerin, and esophageal spasm is one of those. Our patient also had in her history palpitations, and it makes us think about cardiac causes. But once again, we must not neglect that cases are much more complex than that, and we also need to think about esophageal causes, intercostal muscle twitching, spasms, esophageal hernia. And then when we moved forward to the risk factors, the patient had hypertension, diabetes, anxiety, which they all increase the pretest probability of having an acute coronary syndrome. So when the patient presented to the AD, she had hypotension, tachycardia, and basilar crackles, which made us wonder about a cardiogenic shock, but we needed to assess lactate and peripheral perfusion. So this was basically a sympathetic response to what we thought that might be an acute myocardial infarction. And to stratify these patients, we used the KILIP classification, and it's based on the congestion, pulmonary findings, and the 4th class is cardiogenic shock, and it's associated with a mortality between 40 to 70%, which is very high. And moving forward, we also talked about the possibility of maybe this patient having a cardiac tamponade, and we were aware that actually the Beck's triad is rare. She had some right-sided features. She had a peripheral edema, not that significant, but it can happen if the tamponade is chronic. The GVD was hard to assess. She didn't have muffled heart sounds though. And then we saw the EKG, and she actually had no EKG changes, and at the moment she was not having chest pain. We stated that actually there was no active ACS, acute coronary syndrome, happening, but we knew, we were almost certain that there was something wrong with the heart. So the next step really had to be POCUS, point of care ultrasound, to really assess the heart, the heart contractility, effusions, also lung edema. We can also check that, but mostly to see how is the ejection fraction and the contractility on the walls. Our troponin was increased, but then we got to this topic, which is the delta troponin, which is very important, and that really helps us narrow our hypothesis. Is it increasing? And if it's increasing, we have an evolving process, and if not, if it's decreasing, maybe it's just an old MI, which could happen in the case of the patient, because she had this ongoing pain, intermittent pain, chest pain for the past 4 months. So when the patient actually got an echocardiogram, we saw a left ventricular global hypokinesis and less than 50% respiratory variation of the IVC. We ended up making the diagnosis of MINOCA, which is a myocardial infarction that is non-obstructive. There was apical ballooning, which makes us think about the final diagnosis, which is Takotsubo. Regarding some pharmacologic pearls, we should not give nitroglycerin in RV ischemia. These patients are dependent on their preload, and this would decrease preload. And also, before starting beta blockers, the patient needs to be compensated. And this patient actually developed bradycardia, and then we stopped the beta blockers. So that was it. I hope you enjoyed and you learned. Thank you, Ambish. Thank you, Ravi, and all the team. Nice work. Thank you.
Thank you, Francisco. That was very eloquently put. You're very professorial in your deliverance of the teaching points. So I applaud you for that. And thank you again, Ambish. Such a great case. This is very important and something we definitely do day in, day out. So it was great to go through the journey of chest pain and also consider this diagnosis. And I really appreciate Yasmin and Hans for jumping in and also discussing this case. So, all right, take care, everybody. Have a great rest of the Tuesday.
Thank you, guys.
Thank
Take
you.
care.